Um, so I just wanted to first thank everybody for coming this afternoon. Who we have is the Utilization Management Department with us. We have Lance Russell and Cheryl Smith, and a few others. I'll let them introduce themselves. But they're going to be discussing the inpatient versus observation status. I know there's been a lot of new hires and even a lot of questions from some of the older hires that we still have that still kind of have difficulties making the difference with inpatient versus observation. So they're going to be talking about the conversion rates that we have and just how to make the decision with the inpatient versus observation. So I'll let you take it over, Lance.
All right, thanks a lot for the invite to come and share. Can y'all hear me fine?
Yes, we can hear you.
All right, good deal. Sometimes have technical difficulties with this Zoom. All right, we're going to talk about patient statuses. And before we get into the heart of that, I want to lay just a little bit of groundwork to talk about utilization management and why we exist, what we do, and how we reach our status determinations. I think we also need to understand a little bit of the financial impact of the organization about incorrect statuses, and then look at inpatient conversion. And lastly, I've got some actual cases that I wanted to discuss with you all. These are actually hospitalist cases that have been through some of the audit process with Medicare. So we exist to make your life miserable. Right? Wrong. We do a lot of things that encompass a lot of different areas. Some of this deals with risk management, regulatory compliance, basically making sure that hospital performance, what we're giving is appropriate and necessary for our patients. We're active across the healthcare spectrum, certain outpatient, inpatient, psychiatry, rehab, and we want to make sure that we are adhering to all of the payer-specific protocols, that we're getting our status right, because billing is directly tied to all of that. Now, I mentioned we exist to make your life miserable, but we exist because Medicare says we have to exist. Part of our conditions of participation with Medicare is that we have to have a UR plan that provides review of services that we provide as an institution and members of the medical staff to patients who are entitled benefits under Medicare and Medicaid. And medical necessity is a phrase you're going to hear me say a lot today. That plan that Medicare requires says we have to do a medical necessity review on our patients when they're admitted to the institution during the duration of their stay, and that includes all the professional services that we furnish. So what is medical necessity? Well, kind of depends on who you ask, I suppose. Dr. Smith thinks that everybody ought to have a lactulose enema every 2 hours just for good health and regularity. Dr. Jones thinks it should be every 6 hours, and Dr. Kumar says they're all idiots. Who's right? Medical necessity is just simply defined as care or treatment that is reasonable, necessary, appropriate based on evidence-based standards of care. And that's a very important point. Evidence-based standards of care determine best practices, your practice standards. Some of our payers have specific protocols that we have to follow. Blue Cross has their own special stuff. Medicare has national and local coverage determinations that we have to abide by. We also use medical necessity screening tools. Milliman Care Guidelines is one that is used by some of our payers. At UAB, we use the Change Healthcare Interqual Level of Care criteria. And these are the tools we use to help us determine medical necessity. Why is it important? Because payers are not going to pay us for care that they deem not medically necessary. That includes Medicare, Blue Cross, all of our commercial payers. They will deny if we provide care that is not medically necessary. CMS denials are retrospective and can have a larger impact on the financial health of the hospital because depending on how things go with those on audit, we can have our reimbursement rate across the board reduced. And some of our payers may determine that inpatient care is not medically necessary. They may approve the stay as observation. They may decide that an entire episode of care is not medically necessary at any level of care. And usually when our patients are medically stable and ready for discharge, that's when payment is going to stop. And out-of-network payers may not even pay us at all if the patient is deemed medically unnecessary to be in the hospital or once they've deemed stable. So the hospital loses revenue. And whether we like it or not, healthcare is a business, and we have to have a revenue stream. We are seeing the rate of denials go up. It's been up 23% since 2016. It's going up since COVID, and we expect that trend to continue. And when you look at that volume and you extrapolate it, that's somewhere around 1.5 trillion annually in healthcare revenue. And so you look at that percentage and just think about what financial impact that has to the hospital. Medical necessity makes up about 6.6% of denials, and it's really a catch-all category that deals with a lack of medical necessity or maybe an inappropriate level of care. And this is one of the areas where we as our department can make a big impact. And better documentation can certainly impact those determinations. So now I want to talk about statuses and how we determine those. There are only two in the real world. You are either an inpatient or you are an outpatient. UAB likes to complicate things because we break outpatient down into two statuses. We have a bedded outpatient, and we also look at observation as a status, but in the real world, it is not a status. It is a service, and all of our observation cases are reviewed to see if observation charges are appropriate based on payer regulations. All admissions to the hospital are reviewed for status accuracy within the first 24 hours of admission. And we look at observation cases daily, inpatient appropriateness, and we look to see if the documentation supports that upgrade. If so, the UM nurse will enter a verbal order to change that type to inpatient, but if observation is appropriate, no change is made. And there are different criteria that we use for the review, some payer-specific guidelines, I've already mentioned those. Medicare has a 2-midnight rule, which I'm going to talk about in just a minute. And I mentioned earlier the change healthcare interqual level of care. And how frequently we look at our patients who are here long-term depends according to the payer and the contract that we have with that particular payer. Who cares? Why does patient status matter? Matters for a bunch of reasons for a lot of different people. For you as a provider, appropriate level of care for your patient. It also helps with throughput. For our patients, status determines their out-of-pocket expense. And if they get a big bill, it's going to affect patient satisfaction. For a hospital, though, it contributes to our financial health. I mentioned healthcare is a business. We have to have revenue. It also has tied with it some compliance and audit risk that you may not appreciate. I'm going to talk about some of that in a little bit. But it's also a UAB medicine performance measurement, inpatient conversions. I'm going to talk about that as well. This gives you a breakdown for traditional Medicare of how we're paid. Now, Part A pays for inpatient care, Part B pays for outpatient. Part A is a DRG. There is a $1,600 deductible per benefit period, and once we get into day 61 and beyond, they're into co-insurance days, so that can add up pretty quickly. Outpatient care has an annual deductible, but they typically pay 20% of Medicare allowed amount for most doctor services. Each X-ray you order, each MRI you order, ultrasound, they're going to get a 20% copay for that. Routine home medicines and prescription over-the-counter are not covered, depending on hospital policy. And so the total copay for outpatient services could be more than the inpatient deductible. And that's one of the reasons that we look at that. We are also required to notify our patients, and this is federal law that requires us to notify them if they are in observation or have been receiving observation services for greater than 24 hours, that their copays are going to be different. It also can affect their post-discharge plan because of the 3-midnight sniff rule that had been suspended for COVID, but as of the 11th of May is now back into effect. And so we have to provide that in writing and verbally. So let's talk now about the statuses. What is an inpatient? Medicare tells us an inpatient is somebody who is admitted to the hospital bed for purposes of receiving inpatient services. That's clear as mud. They further define inpatient services as those that cannot be safely or effectively rendered at a lower level of care without jeopardizing the health or safety of the patient. Inpatient status begins with the date and the time on an admission order. And that's why admission orders are so important. All of our billing is tied to that. Medicare further says that the decision to admit as an inpatient is based on complex medical factors, including but not limited to history, comorbidities, their signs and their symptoms, the severity, what their medical needs, and the risk or probability of an adverse reaction or adverse event occurring during the time period for which hospitalization is considered. All of these factors that lead to your decision to admit as an inpatient must be documented in the medical record. CMS has a 2-midnight rule, and I'm going to spend my time today primarily talking about Medicare regulations because they are the big driver. The 2-midnight rule does not at the present apply to Medicare HMOs, but effective January 1 of next year, it will. And so that's going to be a big chunk of our payers are going to be following this 2-midnight rule. And I think some of our commercial payers follow something similar to this, but not quite. Inpatient admission is reasonable and necessary if it is ordered based on the expectation that a beneficiary length of stay will exceed 2 midnights, and the record supports that expectation. The record also has to provide clear supporting documentation of medical necessity for that admission. And when we talk about the 2-midnight rule, we can use time in contiguous outpatient services within the hospital prior to an inpatient admission in determining that expected length of stay. So when they come to the emergency department, once treatment starts there, that's when our 2-midnight clock starts. Doesn't start with triage or wait time, but treatment has to be started. That can be labs, EKG, whatever. Observation services count in our 2-midnight expectation, and also procedures in the operating room or other treatment areas like endoscopy, HVC that are considered outpatient areas. For patients who transfer to us, the clock starts when care begins at the initial hospital. And I want to stress today, if you don't get anything else out of anything that I say today, I hope you can appreciate the importance that documentation plays. Medicare and all of our payers expect that the medical necessity be documented. In documenting the 2-midnight exception or expectation, rather, you don't have to write a separate attestation that I expect this person is going to be here 4 days, but we highly recommend it. Expected length of stay, though, can be inferred from standard medical documentation, such as your plan of care, your treatment orders, and your progress notes. So when you are writing all of your notes, details matter. Why do you expect 2 midnights? How did you document this? Was this carried through your documented treatment plan? It's critical that that documentation be there. Details matter. And something as simple as an O2 SAT reading for a patient that is hypoxic can make all the difference in the world in status determinations. We frequently see, so okay, you're hypoxic in the ER. What does that mean? How hypoxic? Was their SAT below 89%? That's one of the cutoffs for our criteria. Those things, though they may seem trivial, are very important in documenting the medical necessity and helping to support the 2 midnight expectation. It's like being back in high school math. We all remember what our teacher told us about show your work. These suggestions here about documentation, I've got them up under the inpatient header, also apply for observation patients. Why does this patient need to be in the hospital? Is this patient unstable? If they are unstable, how are they unstable? Do they need frequent monitoring? If so, what type and why? Any abnormal physical findings, please emphasize those, the vital signs or lab values. If there is a complex plan of care, is that fully documented? What acute needs do we have? Are we doing something that cannot be done in an outpatient setting? Is the patient still unable to walk to the bathroom? Are they still febrile? They're vomiting every 4 hours despite IV Zofran. Those are the kind of details that support an inpatient admission. Can these needs be addressed at a level of care? Have you considered alternatives to hospitalization? Why are alternative care settings not appropriate? And this last point, is the patient at risk for an adverse event if they are not hospitalized? Those are things that we need to be able to see in the record. And these are things that our auditors look at. As the treatment plan progresses, has there been any change in your diagnosis? Has there been any change in your treatment? It is particularly important that you document the patient's progress because that supports continued stay. Are they responding to treatment? Has your diagnosis changed? Has your treatment plan been changed or modified? Progress notes that say the same thing day after day that have been copied and pasted are problematic. It's just a little bit frustrating for me when I audit charts and I see that, and it's really hard to see if there's anything that's changed. Maybe 1 or 2 words has changed in the subjective. Payers may refuse to review notes like that. In fact, we recently had a payer to refuse to accept notes like that. They were copied and pasted. So please be very mindful of that. And the information provided in the note, is it useful? Is it relevant? I know we tend to sometimes on some services get a little bit of chart bloat where you go through about 2 or 3 pages before you get to anything that is relevant. And payers do sometimes balk at that. And so this documentation or lack thereof can put payment at risk. Our auditors and our payers want to know what you were thinking, and they want it clearly documented. And our good documentation is the best way to ensure appropriate reimbursement. So details matter. I wanted to show you a couple of snips from charts that I've audited that show how various doctors have documented this two-midnight expectation. This first one is fairly good because it addresses some of the morbidity, mortality, and that was actually addressed in the H&P and the progress notes. So that one is a pretty good one. The one below, yeah, there's a 4-day expectation, and I don't remember if that was adequately addressed in the treatment plan. If you document that on an inpatient chart, that I admit to medicine for overnight observation, that patient does not need to be an inpatient. That is a major red flag for all of our payers, all of our auditors, and it calls into question the two-midnight expectation. CMS, and I don't think this applies really to hospitalists that much, but there are a list of services that Medicare will only pay for in the inpatient setting, no matter the length of stay. The TAVR procedure is one of them. This list is updated every year by CMS, and usually the CPT code is put in the planning order for planned procedures. There are some exceptions to the two-midnight rule. CMS calls nationally identified rare and unusual expectations, such as mechanical and ventilation initiated in the present period visit. That is an exception to the two-midnight rule. They come in, they get on the vent, get them off, and they may go home the next day. Telemetry alone is not rare and unusual, nor is ICU admission alone a type of rare and unusual circumstance that justifies inpatient absent a two-midnight expectation. You can be in an intensive care unit under observation. I have actually seen that. We had a case on audit several years ago where the Medicare auditors denied it because the patient was admitted in the ICU and there was no two-midnight documentation or expectation there. There are some case-by-case exceptions that CMS allows. Some of these patients can be inpatient under certain circumstances. And again, this is based on good documentation, physician judgment, all of those things that we talked about earlier: history, morbidity, signs, symptoms, risks, current medical needs, even those that diagnostic services that might be appropriately outpatient can figure in. And we are told rarely do stays under 24 hours qualify for an exception. And that is direction that has been given to the auditors, and most of the payers are going to say exactly the same thing. There are some unforeseen circumstances that may arise that result in a shorter stay than the expected 2 midnights. Those have to be clearly documented in the record. Medicine that touches the world gets people better quicker. That's fine, so long as it's documented that they improved quicker. Transfer to another hospital, we rarely do that. Leaving against medical advice, hospice election, or death. And I want to stress this last point. Please do not downgrade to observation at time of discharge if the patient is discharging before the second inpatient midnight. I've actually seen 1 or 2 providers that will do that. They'll put in a change patient type order to observation right before the discharge order, and the patients would appropriately been inpatient. But when that order goes in, then we lose the ability to submit an inpatient claim. And also observation charges begin at the time of the observation order, so we lose that revenue as well. Short stay admissions are a big risk for us because of the Medicare audit program. Anybody who is an inpatient less than 2 midnights after the inpatient order may be selected for review by the audit administrative contractors and the recovery audit contractors. The RACs are people that we don't want to have to deal with, but if we do not do well on our audits, then we may have to. Care rendered for social purposes or reasons of convenience, Medicare payment is prohibited. Any extensive delay in providing medically necessary care is excluded from the 2 midnight benchmark. And factors that are an inconvenience to the beneficiary, family, or physician are not by themselves justify Part A payment. And I know some of you have probably seen this pop up when you are ready to discharge a short stay patient. We put this in several years ago to kind of help us to document why this patient went home in less than 2 midnights. And all of these are the items that Medicare said is okay for an exception. But this is what is probably the most important, is the supporting documentation. This is just a place where you can put a little blurb in as to why this patient got better quicker than expected, they left AMA, whatever. That documentation is extremely important. And I have over the years seen quite a variety of good and not so good documentation. This is fairly good documentation on the form that, they got better. The sickle patient, they got better with aggressive support, symptomatic treatment. This patient left AMA, and there was actually a very detailed free text note outlining all of that. This was a heart failure patient that improved with diuresis better than we were expecting. And so they're stable, and now they're better managed as an outpatient. This was another one that was fairly good, indicating a rapid improvement in symptoms and stability for discharge. This is not good documentation. I had no idea what that meant. But digging in the chart, it means the patient was actually here for 2 midnights prior to the discharge. A period, that's one way to get around having to do that documentation. That is not good. That also is not good. That was actually an attending physician that charted that. Not sure met inpatient criteria to begin with. And then that one. I initially admitted his odds. I got a page from to convert him. I don't know if that was some kind of religious experience or what, but that is not good documentation. Why that documentation is so important, just checking that form is not enough. And this was actually from a recent 2 midnight claim that was denied because that form was there. There was no supporting documentation actually in the record. And so they tell us that just clicking that statement to conform to this 2 midnight requirement is not enough. And it goes back to what we've already talked about, is that your documentation is exceedingly important. Bedded outpatient, is someone who is an outpatient in a bed and they're going to stay overnight. These are typically for outpatient procedures, and even those that don't stay overnight, same-day surgeries, I think, are also have that status. Dialysis patients, who that's all they're having done. Same-day surgeries, not inpatient only. And we have figured into this 48 hours of post-procedure monitoring expected complications. Unable to avoid oxygen weaning are just a couple examples of those. Observation is the one I think we struggle probably more with than anything else. This is the CMS definition. It's a well-defined set of specific clinically appropriate services, including ongoing short-term treatment. Short-term is the key. Assessment, reassessment before a decision is made whether this patient can be discharged or they need to be admitted as an inpatient. Observation is time limited. Majority of the cases, that decision should be made within 48 hours, usually less than 24. Traditional Medicare limits to 48, Medicaid to 23. The commercial payers can vary from 48 to 72. Rare and exceptional cases, and only rare and exceptional cases, do reasonable necessary outpatient observation services span more than 48 hours. Again, observation does not count toward those 3 qualifying midnights for traditional Medicare SNF placement. Medicare does not provide payment for custodial care. When you have a patient that is stable and or improving, and you're excluding diagnoses, that's your typical rule out. Those are cases you need to consider for observation. If you are evaluating a patient and your treatment plan includes monitor and or observe, consider observation services for those cases. If your documentation states we are admitting for observation, that is a red flag that says this should be observation. Admit for placement, social admissions, family drop-offs. I know you all on the hospital services tend to get all of these. Those are a little bit problematic unless there is some underlying medically necessary reason for that admission. Those are generally put into observation and you manage whatever medically is going wrong in them. Inpatient is, I would say, generally not appropriate for them unless there is some underlying medically necessary reason. This is a list of common observation diagnoses. And you'll note most of these, particularly asthma, COPD, cellulitis, heart failure, mild cases of that, probably need to start out in observation, particularly if they have shown improvement in the emergency department. Non-traumatic abdominal pain, dehydration, that's a big one for us. That's a big red flag for observation. Failure to thrive, that's a big concern. Gastroenteritis, hypertensive urgency, migraines, nausea, vomiting, kidney stones without obstruction. Now that could really go either way. Pain control, chronic pain, pneumonia, stroke that's minor with resolving symptoms, TIA, syncope. Syncope usually always needs to start out as observation unless you've got some underlying arrhythmia that is causing it, and uncomplicated UTIs. We have created a patient status flow chart to help guide you, and there's some updates that have been made to that, and I will make those available. I'll send them to Kim and she can distribute them to the group. But this just kind of walks you through the thought process of dealing with that 2 midnights and determining whether it should be inpatient or observation. There's another aid that we will make available to you, and this is the updated one. I'll send that to Kim as well. But this is a document that's provided by Change Healthcare, which makes our interqual criteria, that goes through some of these diagnoses and gives you kind of what we are looking for when we review these cases to support observation versus inpatient. And so I'll make this available to everyone as well. I just want to stress that admit orders are required for all admissions because that is directly tied to billing. And so that's why that has to be there. The order has to be timed and dated. It also has to specify a patient status. It has to be either inpatient or outpatient observation. And it has to be co-signed by the attending physician prior to discharge. Observation billing begins with the date time of the OBS order. Inpatient status begins when the inpatient order is written, and we cannot change post-status, post-discharge for Medicare and most other payers. And I want to stress again that orders may not be backdated. I did run into a situation a couple of 3 years ago where a patient should have been admitted to inpatient and they were needing that 3 midnight stay, but it was observation, did not get upgraded. Now they're ready to go. And the provider went in and put a backdated order in after being told not to do that so that we would get that 3 midnights, or so it would appear to be. Please don't ever, ever, ever do that. Backdated orders are not allowed. That is a compliance risk. And when those things are done like that, and after being told not to, those get a referral to corporate compliance. And I know none of you would do anything like that. If you need to change status, please don't discontinue the original admit order, don't enter a second admit order, and do not modify the admit order for a status change. There are other orders that we can use to deal with that. And of course, you'll have all, I think, probably seen this pop up. This just means when you put a discharge order in that the inpatient order has not been signed, it needs to be by the attending. That is a CMS regulation. CMS is very explicit saying the residents and advanced practice providers are not allowed to co-sign that admit order. So that's why you see that. I want to mention inpatient conversions just briefly. And this is an inpatient admission that is converted to outpatient as a result of a status change order. And it's the total number of IPC orders divided by the total number of inpatient conversions divided by the total number of inpatient orders. And it is a UAB medicine performance expectation that your rate be less than 4%. And here is a chart that shows you where the hospitalist service has been over the last 12 months. The hospitalist is in green. All services are in orange. And your rates have been as high as 6.4%. And we kind of gone up and down over the years. And this is something that we monitor monthly. And I do send a report out to some of your attendings and to the APP supervisors with these rates. And if you're interested in knowing what your individual inpatient conversion rate is, we can provide that data for you. Question. If I expect the patient is going to stay 2 midnights or greater, should I automatically admit them to inpatient status? Only if it is going to be medically necessary acute hospital care provided that cannot be provided in an outpatient setting, or they're having a procedure that's on the inpatient only list. They can be in the hospital greater than 2 midnights and not meet requirement for inpatient status. Can I admit all patients for observation and let UM sort it out? Absolutely no. It is the responsibility of the attending physician or designee to make a decision at the time of admission about their condition and the level of services provided. So no, it is not appropriate to admit all patients to outpatient observation and let the UM nurse correct the status. You have to consider all of those things that are baked into that 2 midnight rule for determining whether they should be inpatient or not. And CMS expects us to get it right on admission. And there are some things that we have to report to CMS when we have to make changes because the status is not correct. And that's a whole nother area in the weeds that we don't need to get into. If the discharge plan is for a SNF, and I admit them in inpatient status so they meet the 3-day qualifying inpatient stay requirements. If they do not require inpatient level of care, they should not be admitted as an inpatient expressly to accumulate pre-qualifying inpatient days needed for a covered SNF. So I want to now look at some actual cases. And the cases that I selected, as I mentioned in the beginning, are cases from our short stay inpatient audit from the hospitalist service that were audited and denied. And so this was a 90-year-old a little lady who came to the ED as a code stroke for altered mental status. Those are always sometimes a little bit problematic, that started the previous night. She was minimally responsive in the ED, proved to be moving her right side. The family noted she had started taking 3 milligrams of melatonin recently, and the patient admitted taking 3 of those pills the previous day. So in the emergency department, her encephalopathy improved. She was still confused, no stroke on imaging, admitted to hospitalist for management of encephalopathy, likely secondary to melatonin ingestion. Medical history, surgical history about what you would expect for somebody her age. What status do you think she should have admitted to? Well, need a little bit more information, right? Blood pressure was elevated, pulse was fine, respiration's fine, SAT's fine, temp's fine. She's improved. CT head is negative, CTA negative. Lab's not that spectacular. Toxicology negative, UA unremarkable, no COVID. So she was admitted as an inpatient. Initially started out with 1 hour vital signs in the ED that was transitioned to 6 daily when the orders came in. Same with neuro checks, regular diet, ambulate with assistance, PTOT. She was discharged the next day with a length of stay of 25.1 hours. This is directly from the history and physical. It states it's an overdose of melatonin, secondary, causing the encephalopathy. All we're doing is holding the melatonin, getting PT to see her, starting back her home blood pressure medicine, giving her Tylenol as needed. That was an observation admission. Never should have been admitted as an inpatient. And this is the rationale that the auditors gave us. She was stable. There's no acute anything going on. Labs are unremarkable. She's back to baseline. We admitted her for neurology evaluation. She stayed 1 midnight. Now, when our auditors look at our charts, they're looking for your documentation and asking, is it reasonable for the admitting physician to expect this patient to require medically necessary hospital services, or did they receive medically necessary hospital services for 2 midnights or longer? No was their answer. The documented plan of care of monitoring neurology evaluation does not indicate a reasonable expectation of a 2 midnight stay. They also asked, does the record support the determination that the patient would require inpatient care despite not meeting the benchmark? One of those exceptions, one of those case-by-case exceptions. Their answer was no. Monitoring and neurology evaluation and a patient with resolved symptoms do not meet criteria without a 2 midnight expectation. And so we had to pay money back on that one. This next patient was 54-year-old who came to the emergency department with nausea, vomiting, epigastric pain. History of gastroparesis, gastric stimulators, on dialysis, diabetes, hypertension. ED workup shows mild ground glass opacities, likely volume overload, no ischemia on EKG. Troponin is flat and stable. Renal markers are where you would expect for a person like this. Low hemoglobin, hematocrit. Slight hypoglycemia that got better with dextrose. They got multiple rounds of antiemetics and pain medications without lasting relief, admitted inpatient status with a diagnosis of gastroparesis, with a plan of care or a GI consult and supportive care. We got 1 midnight, but it was a 23-hour stay. And this is the documentation that was actually on the less than 2 midnight form. I got better sooner than expected. And I guess that last statement, not really sure what to make of that, and be improved and he tolerated. I guess that would be PO intake. So this is a rationale. This is another one that would have been appropriate for observation. Nausea, vomiting, epigastric pain in a patient with these problems does not really support inpatient status because we get a little bit of fluid, monitor, an advanced diet, and dialyze. So was the 2 midnight expectation reasonable? The auditors said no. That if you got an acute on chronic, and that sometimes also can be a little bit of a problem in terms of status when you've got an acute or chronic exacerbation of something. Nausea, vomiting, epigastric pain, and that plan of care, it was not reasonable to expect 2 midnights to complete. Did the record support an exception to the 2 midnight rule? The answer was no, because the patient was mental status was stable, no changes. EKG was fine. There was no increased risk for this patient. The patient was stable, and so they were discharged. And so we had to repay some money on that one. This patient was 80 years old, coming to the emergency department with nausea and syncope. Syncope and nausea, those are our common observation diagnoses. Hypertension, lipids are high, PAD. She had a history of ovarian leiomyosarcoma. Systolic en route to the ED, but when she gets here, she's awake, confused slightly. No neurological deficits. Blood pressure was fine. EKG is NSR without ischemia, arrhythmia. White cells, leukocytes in the UA. She got some Rocephin. CT angio was negative. She was admitted as an inpatient and discharged home the following day, 1 midnight, 20 hours. Syncope resolved. The auditors looked at this case and said ED showed a UTI. Her white cell was normal. She was stable. She was admitted for monitoring, antibiotics, and your home meds. This would have been another one that observation would have been more appropriate on. Was it reasonable to expect 2 midnights? The auditor said no. The plan of care is uncertain, pending response to treatment. And that's one of those, if you're not certain and this patient is stable, it's better to go observation. Plan of monitoring and antibiotics in a patient who is stable without sepsis does not indicate a reasonable expectation of 2 midnights and needing to stay in acute care. Did it meet one of those exceptions? They said no, because she was stable. No acute interventions expected. No increased risk or probability for the time period for which hospitalization was considered. So these are the kind of things that we have to deal with, particularly with our documentation, making sure that if we are going to admit somebody as an inpatient, that the documentation is good and it supports it. So that's all I had for today. I want to open up the floor for any questions that you all may have.
And she did a great job. One thing that I've always been confused about is when we as medicine are admitting psychiatric patients, especially with like suicidal ideation, we know they're going to be here until site clearance, but really not a lot going on from a medicine standpoint. Are those better for us to admit as OBS?
I would say probably so.
And then my other question is there anything that you specifically have seen from our service that you think would be, like if you could just change one thing on our service that you think would be very helpful for us to know?
I would stop copy and pasting notes. And I would. And notes earlier in the day, that's one of the things that we struggle the most with, I think, from a review standpoint, is notes that get added to the chart late in the afternoon. It's really hard for us to make a status determination without that. And sometimes the nurses will call and ask whoever the provider is, what's the plan of care? And it looks like there's going to be here for another 1 to 2 days, and they wind up discharging about 2 to 3 hours after we do a status upgrade. So those are things that would be quite helpful for us in terms of your service, getting those notes in earlier. And I know that's maybe sometimes a losing battle because of the sheer volume that you all have to do. But yeah, that copy and paste, that's really something.
Yeah, I think the notes thing is probably rough for y'all because from a workflow standpoint, most people need to do their discharge summaries first if someone's going to a SNF. And so not very helpful for y'all, but from a workflow, you need to get the SNF discharge summaries in, it kind of delays. Yeah,
observation cases, if those notes went in earlier, that would be really great, because then that gives us what we need to make a status determination. And we also contract with a physician advisor group that we can send these cases out to and get another physician who is not affiliated with the hospital, look at them and kind of advise us. And one of the things that they always put in their determinations is, what they see as the risks or the probability of something adverse happening. And those, if that were added to the progress notes or the history and physical, I think that would also be quite helpful in terms of supporting inpatient status.
Anything from the initial note, any diagnosis that we tend to fail on a pretty regular basis?
I can't really say one that we fail on a pretty regular basis, but anything that's on that list of common observation diagnoses, that sets us up for failure. Unless the documentation is really there that lays out the treatment plan, those risks, and particularly if it's somebody that's stable.
Sure.
I may have missed it earlier, but that list of procedures that are inpatient only, was that in the was that in the PowerPoint?
It was, yeah. It's let me back up. And our nurses all have a copy of that list. So if you're interested in getting a copy, we can we might be able to provide that for you. But usually by the time if they're coming in specifically for surgery, we're going to get them early on in the admission and get them into the appropriate status. And you all may get them for follow-up care. Total hips, total knees, those are recent. Well, I say recent, within the last 2 to 3 years. Total hips came off the inpatient only list, and that drove us all bonkers. And even some of the total hips are now being done in ambulatory surgery centers and going home the same day.
And then I also had a question about so as far as copying and pasting notes goes, is there a particular area, like you mentioned subjective earlier, it's like, someone just doesn't change subjective for several days or something, but are there other like particularly problematic aspects of it? Like you mentioned bloat, but if we're, relatively conscientious about reviewing the notes and taking out redundancies and keeping the impression up to date, it's hard to completely and totally discontinue that practice because especially if people have been here a long time.
Yeah.
Patients better.
Yeah. If you're conscientious about your notes, you're reading, approving them, making sure that the needs are and what we're doing is addressed, that's great. That's fine. No problems with those.
But is it helpful for you guys if we do have say like a list of resolved diagnoses or active versus inactive? Or, I don't know. Is there something like that that would be helpful?
I don't know that active versus inactive. And I mean, if we're treating it, I think sometimes y'all document that whatever we're treating is resolved. And if I remember correctly, the average number of diagnoses that a UAB hospital patient has is somewhere around 12 or 13. And some of those we may be doing some kind of active management on them. But yes, if something is active and we're actively treating that and you're documenting that progress under that particular heading in your progress note, that's what we need. And if something has resolved, just saying this is resolved, that is quite helpful for us.
And then also one more thing. That you mentioned a blurb about kind of where we're at with the expected day of discharge or length of stay. Like, is that something that if that was updated routinely in the note, that would be helpful? Did I catch that right?
Yeah, if that is addressed in the notes, that is quite helpful. We do appreciate that because that helps us to support that to midnight expectation.
Okay.
But just that blanket statement though is not enough. It's got to be supported by your plan of care.
Okay. These are the barriers. This isn't going to take place until Monday. Blah blah blah. Something like that.
Yeah.
Okay. And then for those of us who auto-populate, say the patient's vital signs. Okay. If I was to write, acute hypoxic respiratory failure, but then you look up under the physical exam, and you see where it says, that the patient's lowest stat was, 78% recorded in the last 24 hours or something like that. Adequate?
That is adequate as long as it is documented in the record. And what I have seen in some of the charts that I have audited over the years is looking at that, the diagnosis of respiratory failure, they desatted when they ambulated, but then I look in the notes, all I see are SpO2 of 92 to 100, and even going back into the emergency department, we don't really see anything other than that they were hypoxic. So it's kind of hard to tell exactly what that means. So yeah, as long as there's a number documented there, that is quite helpful.
Okay. So anything below 92% meets that criteria for you guys?
89.
Or
89 is what most of our interqual criteria look at, but even that alone is not enough. It has to be some of that other stuff that's there. But yeah, 89% and below is really helpful. And also from a case management perspective, a room air sat, I know they have to have it at a certain level before Medicare, some of these other commercial payers will cover home oxygen. But that's usually getting close to discharge. Once all the treatment's done, they take them off our oxygen, get up, ambulate them, and get that room air sat. And I think it has to be, if I'm not mistaken, it has to be below 90%. I may be wrong on that.
thank you.
Details and documentation matter.
Yeah, I was just gonna say, Lance, I don't want to make everyone fearful of making anybody inpatient with the denials. And I know that, do you guys still have someone around 24/7 that they can contact if there's any questions or something?
We have a nurse, during the day, a hospitalist, I think, has 3 or 4 nurses specifically dedicated to the hospitalist service. On the weekend, we have an ED staff that's 24/7, or 24 hours a day on the weekend. On weekday nights, we have somebody available until 2 a.m. in the emergency department. So yes, we are happy to talk with you all and answer any questions you have if you can't quite make up your mind which way the status goes now. Yeah, I don't want to scare anybody about putting inpatient on the order either, but we just have to make sure that we've got that supporting documentation there.
It's just Tuesday through Friday.
Okay.
Monday is to 11, I believe. I believe that's correct.
Well, thank you, Lance. I think you did an excellent job. It was very informative. Does anybody else have any other further questions or comments about anything? Okay, I guess we'll end it for right now. And Lance, if you want to send me the contact of how to get a hold of someone, if they need to reach someone in utilization management, if they're having issues or problems with a status, I think
Certainly will.
know how to reach them, but we can be out there.
Sure.
Well, thank you very much. We appreciate it.
It's our pleasure.
Have a good one.
Thank you. Bye-bye.
Bye.